morning, everyone. I'm presenting a case, third nerve palsy in case of pituitary macroadenoma. Introduction. The third cranial nerve or oculomotor nerve has two components, parasympathetic and somatic. Third nerve palsy has a variety of etiologies which may be due to different serious underlying pathologies like ischemia, tumors, trauma, hemorrhage, congenital, and idiopathic causes. Patients presenting with pupil involvement are usually due to compressive causes, and pupil sparing cases are seen in cases of ischemic causes. My patient was a 35-year-old female with a history of drooping of left eyelid and outward and downward deviation of left eye for 15 days, which was preceded by recurrent episodes of mild left-sided non-radiating headache, which lasted for 30 minutes. Her uncorrected visual acuity was 6.6 in right eye and 6.9 in left eye respectively. Best corrected visual acuity was plain 6.6 and 6.9 in the right eye and left eye. Pupillary reaction was normal in the right eye. The left eye pupil was fixed and dilated. Her anterior segment and fundus findings were within normal limit. On cranial nerve examination, all the cranial nerves were intact except for the left third cranial nerve. FDT and FGT were negative, that is, there was a paralysis of the left lateral rectus, and on FGT, no muscle power was felt. On PBRT, left exotropia of 30 present diopter with left hypotropia of 10 present diopter was seen for both near and distance. On word food dot test and diplopia charting, cross diplopia was observed. Her blood investigation was done, which was within normal limit, and RBS was also within normal range. Hormone profile was normal. For ptosis evaluation, her MRD1 in the right eye was 4 mm and minus 4 mm in the left eye. MRD2 was 7 mm in the right eye, and in the left eye it was 6 mm. Vertical fissure height was normal in right eye, and in left eye it was 0. Lid crease height was 7 and 8 mm in the right eye and left eye. LPS action was 17 mm in the right eye, and in the left eye it was not present. Bell's phenomenon was good in the right eye, and in the left eye it was poor. Corneal sensations were intact in the both eyes. These are the slit lamp images of the right eye and the left eye. On MRI, a well-defined lobulated homogeneously enhancing solid lesion involving stellar and suprasellar region with extension into the left cavernous sinus was seen, which was pituitary macroadenoma. On perimetry, the left eye perimetry couldn't be done due to complete ptosis, and the right eye perimetry was near normal. There was nothing significant. On OCT findings, there was RNFL thinning in the left eye. Apart from that, everything was normal. My provisional diagnosis is pupil involving left oculomotor paralysis due to pituitary macroadenoma. She was operated for it, and a transnasal resection of pituitary adenoma was done on 10th April 24. These are in 9 gaze images in which we can see that the left eye is outward and downward deviated. These are the post of 9 gaze images of the picture in which there is no improvement. Isolated third cranial nerve palsy with pituitary macroadenoma is a very rare cases with few reported cases only, and the patient passed away after 1 week of the surgery while admitted in the ICU, which was possibly due to hyponatremia. Clinical implication: due to mass effect of the pituitary macroadenoma, there is compression of the left third cranial nerve causing ptosis, diplopia, and limitations of the ocular movements. And in my case, despite surgical intervention, the patient passed away. Take-home message: the underlying cause of third cranial nerve palsy should not be taken lightly and be investigated for any vascular causes like undiagnosed diabetes or compression from neoplasm. Earlier detection of the underlying etiology allows a better prognosis due to timely intervention and treatment, as it can sometimes turn deadly.
When you are evaluating third nerve palsy, what are the points in the history which indicates you to do the blood tests or investigations like MRI? What is your sequence, and what are the key points while evaluating when you decide which investigation to be done first?
Ma'am, this was an isolated case of third nerve palsy. Usually it occurs in association with other nerves adjacent. So we thought that it could be due to pituitary involvement.
No. Would you be seeing the history, the age?
Yes, ma'am.
So depending upon
Patient's
that, you will
profile,
see,
ma'am.
and what are the risk factors associated in this patients. Accordingly, you will think of the DDs causing the third nerve, and then you will advise the investigations as per in that protocol. So that's what I was asking.
Yeah, so in continuation, you're saying this was an isolated third nerve, okay? So in isolated third nerve, when would you image and when would you not image?
Like we do imaging for all cases, ma'am.
Not necessarily that you'll do imaging. That's what she's asking. So if it's an isolated complete palsy and pupil sparing in a patient who has a vascular risk factors, okay, like an elderly, diabetic,
Yes, ma'am.
hypertensive,
Ischemic.
those could be pointing towards ischemic. There might be past history of ischemic nerve palsy which covered on its own. So these will tell you, okay, you can wait also. Ideally, yes, you should image because there is a 10% chance that these may also harbor some malignancies or some tumors or compressive causes. But that is where you can still wait and see for progression or betterment over the next few weeks, okay? But if it's a incomplete third nerve palsy or pupil involving, then definitely you have to image. If there is a less age, then you have to image. Any other allied signs like a proptosis, other cranial nerves. So along that line, again, one more question probably. How do you check for fourth nerve in the presence of a complete third nerve? How do you check for a superior oblique involvement?
Ma'am, ma'am, we can, on the basis of extraocular movements, ma'am, we can see.
So how do you check for superior oblique in extraocular movement?
Like intorsion would be affected.
So how do you check? Clinically, how will you check? This is the third nerve palsy. Like normally where you check the superior oblique muscle? You ask the patient to adduct the eye and then depress, right?
Depress, yes, ma'am, forward.
So in third nerve, the patient won't be able to adduct only. So how will you check for a superior oblique? This patient might as well had a superior oblique also involvement. That's also in the cavernous sinus, right? So how do you check? You know that? So mention little bit. So if the superior oblique is there, then while trying to adduct, depress during adduction with the eye adducted, there would be an intorsion. So that intorsion function would be intact. But at depression you won't be able to check because eye won't be able to adduct. Okay, so if you adduct and then you ask the patient to look down, although he won't be able to look, but in that process if the eye intorts, that means the fourth nerve is intact. Okay, thank you.